We'd just like to invite the panelists onto stage. We just
For the panel discussion, could we have Dr. Bavaskar, Dr. Ritu, Dr. Shaini, and Dr. Sujoy up on stage? We'd also like to invite Dr. Anand on stage for the panel discussion.
We've got one written question from the group, but we'll leave this as an open session. We'll just, if a show of hands, and I could also take questions from the audience for the panel. So thank you so much for joining us again on stage. And we'd like to thank Audrey and the team who helped make the summary. So I think in a way, it's a summary that was kind of ringing through every day, different ways of ensuring equity in health, be it in education, service, or research. And that's how we look at it in keeping with our vision statement. I'll just go ahead and to welcome again to the panel. And this question, I will just go straight. Maybe I will ask Sujoy, because he's worked with us for some time. And in CMC, is it possible for a CMC-like organization like CMC to support research in rural India with non-mission organizations?
Yeah, that probably somebody from CMC should answer that. But then I don't find there is a problem, because already that has been happening. No, I'm sure there are some models in which that has already worked. In many research that already had done in multi-centric researches that has been done. I can remember at least 2 of those instances where it was already done in that manner. So I mean, better.
Dr. Anand?
Yeah, I think that what does one mean by mission? Is mission for mission hospitals, or is mission for the country? And that has to be answered.
Yeah.
So is the purpose of an education for the whole country? And so then research should not be confined to mission hospitals, should be confined to where need is and how to address it.
So I could just add on from, as Sujoy rightfully said, that somebody from CMC also has to answer the question. I'm currently holding the mic. But under our research funds or planning on the department, we also have special grants which are given for research that is done in partnership with missions or with secondary hospital organizations. So it's kind of collaborative. And from the principal's office, we do have these projects going. But I suppose what we need to give is feedback to the principal's office, who is the office which conducts this, that there are many more organizations who would like to involve in research with CMC, and it will be definitely beneficial both ways. In a recent learning, we've started a lot of undergrad research where we give very, very simple topics, but it's the first taste for our undergrads to actually work with patients real time, not in the setting of a classroom, but in the setting of actually going out and talking to people who they know only about in textbooks, but actually in person. And we need to expand the scope to them going into the community and actually talking, because I think the whole heart for that and for the community starts when you're an undergraduate, if not before. So that's something that we could do. I'll ask, Shini's been our student, so I will ask Shini, if you look at the way, the training went by when in your undergrad time and what all the discussions are happening, can you tell us a viewpoint as to how we can enhance our, undergrad training to include health equity and all the various things that Audrey was presenting?
I find that the medical training I received in CMC, not only did it help me very well clinically, because I mostly worked in low resource, high insecurity areas, but I always ended up being one of the best clinicians in any team that I worked in. I think a clinical acumen that a broad clinical acumen for most primary healthcare disciplines is essential for most primary healthcare doctors, so that you even pick up things that may be a low priority to the patient, but you automatically pick it up, and then when you integrate services, you can automatically refer them to the right services. A clinical acumen, a broad clinical acumen about most common hidden things is essential. but we also have to understand that CMC is a little bubble of progressivity among a broader world with a lot of inequities. These discussions might seem like repeated and redundant in CMC, but they're very essential out there in the real world. Even where I come from in Andhra Pradesh, the approach to medical care, the approach to healthcare is very different than what we are used to. So, so there is definitely scope for improvement. Like some of the speakers have spoken about gender sensitivity in medical education. There are just a few improvements and modifications I would suggest, but by and large, I am very satisfied and I feel like it has helped me a lot.
Thanks, Shaini. It's good to know there's always room for improvement, which we learn from here and we constantly continue to learn. This is also a question regarding CMC, so I'll come back to this question to the person who sent it, from the person. Dr. Ritu, you did, as Auden rightfully said, defined it at the beginning of the workshop itself. How should we look at equity? Through the 3 days, what was your feeling listening to everybody? Like we've heard from within CMC, from outside of CMC. Are we all somewhere going along the right track? I know some of you all are already friends, but you listen to a lot of people who are outside of your circle. What is your thoughts on what all you heard?
Well, I think I need to first acknowledge really that what the hope I had expressed at the beginning, that in these 3 days there'd be a lot of learning for me from the clinical experience and the efforts that people around the room are making. And that has certainly been completely fulfilled. The kind of generational mix we saw, and each one being able to express in different ways their own experience, coming from the heart with sharing of things which are very personal and experiential. All of that was great learning. I'd like to reflect on 2 dimensions that I mentioned then, and I think which have been referred to by many people, the politics of knowledge being one, and relating that to both pedagogy and then going on from there to where I think what we can do from the learnings that we do get from around the room. I just attempted to look at how politics of knowledge had got represented in the various presentations by the book that Anand had referred to earlier, which has recently come, Dreams of a Healthy India. In the article there, I have tried to look at the various elements of politics of knowledge in healthcare and put down 8 elements. So I just sort of for myself looked at, against those 8, what have we come up with? The first was about what is healthcare itself. How do we look at that? Because if it's medical care, it means one thing, but obviously here, and our title was clinical approaches to addressing inequities, but everybody's definitely gone well beyond that as a definition of healthcare and gone into many other directions than the clinical. So that has been well addressed. We're also looking at equity in access, but the issues of empowerment came in both with palliative care kind of work, the Ladakh kind of work and others, where community was involved and mobilized in so many different ways and empowered, other than empowering other health workers and clinicians across the country. So there are various forms of empowerment that have happened in this definition of healthcare itself. Whose problems get addressed is an issue. And very clearly, consciously, one could see that elements of bringing in those which are often diseases of the marginalized section of the poor, Kala Azar, Leishmaniasis, sickle cell anemia, malaria and malnutrition, lean diabetes. I mean, these are all very clear examples of, so that is another dimension of knowledge which came in, and the social determinants of health coming in very, very centrally and very effectively, of manual scavengers, women in prostitution, men having sex with men, and a whole lot of those kind of categories who we see with homeless people. The third one would see in terms of the way healthcare systems respond, and an important dimension is appropriate technologies, which again, so much of it was demonstrated, so I don't even need to elaborate on the number of those that were there. Evidence-based medicine and its problems is something that was implicitly there, but not adequately teased out. And I think that's an area which we need to go explicit about and talk. There's obviously practice-based evidence medicine and its implications in the new designs and models that are being pioneered here and in other, what we heard. And yet we're not looking at it as something which is critiquing that evidence-based medicine model alone and the insistence on it and highlighting the practice-based evidence. So can we bring that out more and make it mainstream and sort of consciously do it in that way? Epistemological diversity. Again, that's not very much part of what we are doing here. It's also because we are practicing modern medicine clinicians, and that's our major task, and we want to do that well and rationally. Makes perfect sense. But we also have, as the Ladakh experience was one which even talked about it more centrally in terms of the oracles. And he spoke of the oracles because that's easy to put aside, but not talk about Tibetan medicine, which is not that easy to put aside because it has its own system of diagnosis, medicine. So it has its own science, if you want to call it that, or proto-science, if you want to see it that way. But it has something which can challenge our moorings, our theoretical paradigms. And therefore, we just put it aside and don't even engage with it. When I asked the question, Dr. Norden was able to bring out what are commonalities with modern medicine, and therefore it's acceptable. But if it's a completely different epistemology, then do I not want to engage with it? Right? Now it's a difficult question, but it's a question which is societally out there. And we will have to respond to it in some way and engage with it. So I think it means many more of us to engage with those epistemologies and then decide what is, engage with them and show what is limitations of them or the strengths of them, and then bring them out for societal benefit. So that's an area which I think is something which we need to figure out how to get down to doing. The next two was really about, and that's the last one, social science and biomedicine. And biomedical science. So clearly everybody here agrees that social dimensions are extremely important. Inequities come out of that, and understanding inequities requires that. How do we get to it? I think each one of us is exploring in different, what readings we come across, what we are able to get from others, and so on. And therefore one hears, think that humanities is important, but somehow social sciences, which willy-nilly come in, and if you look at health systems research, it's basically development economics and management studies which comes in and makes health systems really management oriented. As if they don't have, social science doesn't have to contribute. Sociology, anthropology are areas which are very different social science. So we can't just lump social sciences as one and say we have to get, and if I get economics in, I've got my social sciences in. That anthropological and sociological understandings need to be studied again. So I don't know whether in our curriculum we bring in social sciences at all. We used to, when I did medicine, have 1 week of other systems, and you'd have 1 lecture each on Ayurveda, etc. One person telling you the titles of all, the names of all the various disciplines and what each one was sort of addressing, and that was it. So I don't know whether we progress beyond that. But I think there's a certain need for it. And whether community medicine brings it in or each department brings it in as they think relevant, but it's definitely an area which needs to be brought in. If equity is to be addressed, then we need deeper understandings to be able to develop our own models and ways of handling it. And finally, governance and the role of knowledge in governance and decision-making in governance. How does it happen? That's the kind of areas where political science teaches us. So again, political science, another social science, which we could delve into if we want to understand those dimensions. And certainly, therefore, how governance systems, which knowledge do they pick up? So is it, you have between international models and prescriptions that come and indigenously and endogenously developed ones. That's one kind of broad kind of thing. And now today in health systems research and in the Lancet editorial and so on, you're seeing decoloniality as a, sort of becoming a buzzword. But what implications does that have is not really getting spelled out. If it just means that you should have a brown or a black author as the first one, and then all the rest can continue, and the ideas can continue as they come from the West, then that's not really happening. So how do we get, understand that and be able to impinge on it? So that's where the pedagogy and research for each of us would go. In terms of what we can do together, that was the second, and there I felt that what one heard in these 3 days in terms of models and different technologies, I think we're talking about it, case by case, one by one, with a lot of humility and confidence. We need to assert, and if you see it together as a stream of thought and a kind of knowledge paradigm systems, then there is enough material from what I can clearly see, which is there to assert it's a separate paradigm which today has answers for today's healthcare crisis, not only for the LMIC. Even the HICs, the high income countries are in a crisis, and these would be good solutions for them. The secondary hospital kind of models, the appropriate technologies. So if we put them together in one and extract principles and lessons from all of them together. When we talk of each one, it's one answer to one. It's like a disease by disease problem that we are solving, but we're not looking at the entire. So in the same way, for health systems design, can we assertively put it out and assert that this is a different paradigm which is appropriate, which can get you equitable and sustainable healthcare in the present world? And that, I think, would be a task for the likes of people in this room to do. Thank you so much.
Thank you so much, ma'am. I just think what ma'am actually, I can never summarize that well, but in a way, I think we are looking at an immersive experience. You have to be in it to learn about it and then come back home and then do something about it in literally those words. And I think classically, when we had all of our secondary hospital programs and other programs, it at least gave a kind of a small time for our UGs to kind of go and immerse themselves in it. We're trying to do it for our postgraduates also, but that's just the CMC experience. But ma'am, as you rightfully said, so many little nuances that we kind of underplay, but it's actually very important and it has to be forward now. We have to do all of that, be it practice-based medicine versus, all of the sciences that we don't talk about. And lastly, of course, how to put it out there and practice it. So thank you, ma'am. I think your notes anyway, you have given your answers to the group also, ma'am, because we may be looking it all over again based on the answers to the questions that sir asked. Please do, because we're kind of putting. Yeah, please, ma'am. Please go ahead. Please go ahead.
I just wanted to really underline and echo what Dr. Yogesh gave us yesterday about how to go ahead with the pedagogy, where he talked of active listening, lived experience, the socio-medical rounds that can be done regularly, and asking the right questions. And I just add to that the right questions from a bottom-up perspective of people's perceptions, and from there draw those. So the first 3 would be to get us to ask those questions from their end. And then if we can do the bottom-up and our top-down expert perspective, which is equally important, together and do that bridging. That's really where we are looking at.
And I think it's simple enough to do. Yeah, that's why that suggestion would be the simplest to do and very practice-based.
That's the challenge. Yeah.
That's the challenge. To remind ourselves constantly that that's what we need to do with every patient we see or every situation that we are in. But I'd just like to ask Dr. Bavaskar. Dr. Bavaskar has shown us from being right where he is, he did a lot of it. Sir, were any of your publications rejected, sir? Were any of your publications rejected when you sent it?
627.
So I think that helps. I didn't want to bring it out that way.
Which
Please, sir.
35 is accepted.
35 words.
And average Lancet acceptance rate is 5%.
Yes.
My acceptance rate was 4.3%. So I was up to that. Now I must congratulate to CMC to bring such conference for 3 days. And really it is understood that what is today's health of our nation. This everything is given. What is today's health? Why? What we need? Everybody was expressing what they experience, what today we need for our nation. And we must repercuss them. That the repercussion is very important. And CMC should give actual how CMC can go ahead. One, they can make a team of few students or few important, brilliant, or interested, passionate students to take out one problem, solve the problem, and then come to the CMC again. So this is very important. We expect CMC the topmost. We accept the topmost research from CMC. This is very important, and this can be done at CMC. Everything is available today. Everything is available. They have, and now this all readers, all presentation has given us food. Provided you must digest now.
Sir, I could just ask Dr. Anand the question. This was again from the CMC Bhopal. How can CMC help young doctors work in rural and peripheral areas outside of the mission network? It's similar to the previous one regarding research, but this is about clinical practice.
Yeah, so I think we heard about the travel fellowship and the rural sensitization program. Those are concrete examples of what is possible. I think in various ways, CMC has explored different ways of using the mission network to sensitize. But there are limitations to the secondary hospital posting because essentially mission hospitals primarily are service organizations which provide clinical care. But they are not necessarily focusing on comprehensive primary health care, which only some of the mission hospitals are doing. So I think where the travel fellowship and RSP go beyond that is really where the center of gravity of the education is actually outside. It's not in the medical college. And I don't know whether Praveen used the term in this presentation. It is an on-college approach. So the strength is actually that it's organized from outside. And as Sarah and myself work with the centers which are doing that, that provides a different experience and motivation. So I think in CMC, one should not see, I think, oneself separate from rest of education and the rest of the problems. I think what we have seen in this conference, the strength of which is the diversity of representation and perspectives. And I think that same idea, given the complexity and sometimes the despairing nature of today's situation, only the strength actually is in everybody in this room. And I think that whether we look at education or research or in health systems or advocacy, different voices have to come together. The issues of low-cost generic drugs is not separate from the issues of manual scavenging or the issue of gender minorities. And I think different voices holding together. So I think education has to move out of what we think is mainstream and really work with trying to understand the problems of different communities and using other networks.
Yeah. Thank you, sir. So in terms of, I think based on the various talks and an answer to helping, I think in a way we have created systems now. We have multiple WhatsApp groups or hotlines kind of thing developed for the right reasons. And with the Poison Network and other such networks, we're actually reaching out to people who can, ask us directly. You have a doubt, we'll give you real-time answers. But of course, the people giving the answers also have to be sensitive to see where is that question coming from and not give a tertiary care answer, which unfortunately can happen. So we learn from the queries. So we are all in terms of now it's personalized networks. People who know people will ask them, hey, I'm stuck in this situation. What do I do next? But we discovered that when our faculty go for the secondary hospital programs, they make contacts. And in fact, they still have people from those hospitals reaching out to them to say, okay, can you help me in this situation? For us, we are strengthened by our practice of general medicine because we are given a lot of freedom and rights, even though we're a tertiary care, to do a lot of work which is beyond, which may be in the specialist realm. So we're able to reach out and help to many queries. So right now we're working on personal connections or people we know. But I think what we need to strengthen is to make it like stronger and more official and open so that anybody can pick up a phone and call the right people to get the right answer. So that is something that we may have to work on. The good part about COVID, as I say, was that we all learned how to use Zoom and many of the online technologies that we may not have known otherwise. So those kind of links can be formed to give ready answers to people on the ground with real-time situations with patients. I think Dr. Bavaskar also mentioned, they showed the telemedicine of the child with and all he did was put the NG tube, they can't swallow, give the Prezocin, because he was strong in what he knew about it. So those are the kind of linkages in which we can help young people outside with situations that they don't know what to do. For us, it works on personal contact, but I think we are large enough now to kind of move beyond that. Dr. Sarah, would you have any questions to ask? So, Dr. Sijoy, I just want to ask, you did mention about, you should actually calculate the prescription ranitidine and the drug cost in a way. And do you all only get generic drugs, or how do you all manage in OTC? What is your recent change? Has there been a change in prescription, drugs? Are you able to access generics easily?
Yeah, we use quite a lot of generic drugs, but not all drugs are available from these. Mainly, we had two major sources for procuring these generic drugs. But many drugs which are currently used, some of them may not be available in that. So in such situations, we have to do quite a lot of work. There is a pharmacy committee who really looks at it. And once the request comes from the clinician side, whichever the department, once the committee feels that it is something that is going to be of use for the patients, then they look out for which is the most affordable, cost-effective option, and then get into a dialogue with that particular vendor. And then, as I already mentioned, we ask them to cut out on all the fringes, all the freebies, anything that is other than the medicine, to cut it all out. And no extra tea or CME or a journal or anything, but put it all into the drug and bring down the prices. As Kalantri sir was showing the differences of the generic drug versus many of the so-called good brands. So it's almost similar type of a bargain we are able to get for majority of the drugs, not all, but majority of the drugs. That helps.
Thank you so much. And I think as medical teachers, we also encourage our interns to write the generic name. Once you write the generic name, you're already empowered to choose between companies rather than writing a certain company and getting the cost already added on. So that's one thing that we should continue to do. This is open to the audience also here. Any questions or comments that you all would like to ask the panel, or generally talk about what you all have heard or experienced in the last 3 days? I know there are many more experiences here. Yes, please.
Yeah, thank you very much. Yeah, I just want to say a few things. I am one of the very few from non-medical background. I think that speak volumes about equity and inclusive already on this medicine annual conference. I want to thank you, the CMC General Medicine Department, Dr. Anand and team. Yeah, just like to highlight few things. I think it is very important to have a healthy kind of coordination and collaborate with media at this age. So whatever we do, I think we need to involve the media. Social networking is, I think, one of the very important factors. Nowadays, even in every rural villages, there are mobile phones and people access to WhatsApp and Facebook and like only any online platform. So I think that's one thing. And second thing is, it is also probably good to involve some legal expert in this conference, because there's a legal implications in all things we do. And the third thing is, it will be good to also include a topic on like managing mass casualty incidents in a disaster settings, or how do we respond to outside of hospitals during disasters, like in terms of relief camps. And I think that could be a good thing. Thank you.
வணக்கம். டாக்டர் பவாஸ்கர் அவர்களுடைய புது அணுகுமுறைய ஒரு குறுகிய கால பயிற்சியா எல்லா பகுதிக்கும் கொடுத்தா நல்லா இருக்கும் நான் நினைக்கிறேன். இது ரொம்ப பயனுள்ளதாகவும் ரொம்ப எளிமையாகவும் சீக்கிரமாகவும் குணமாக்கக்கூடியதா இருக்குது. அதனால அவர் ஒரு சின்ன புதிய சிலபஸை உருவாக்கி படித்த மருத்துவர்களுக்கும் சரி, செவிலியர்கள் இருக்கிறாங்க, அவங்களுக்கெல்லாம் சரி, இந்த சோஷியல் ஒர்க்கர்ஸ் இவங்களுக்கெல்லாம் அவர் ஒரு பயிற்சியை கொடுத்து ஆன்லைன்லயோ இல்லைன்னா நேரடியாவோ செய்தாக்கா நிறைய பயனுள்ளதா இருக்கும்னு நான் நினைக்கிறேன். அந்த வேண்டுகோளை அவர்களுக்கு நீங்க ஆங்கிலத்தில் சொல்லுமாறு நான் கேட்டுக்கொள்கிறேன்.
My translation may not be precise, but I'll just say that as sir requested, we would like whatever Dr. Bavaskar has shared with us to be again shared, both maybe as a pamphlet and a little small meeting with the people that he mentioned, social workers and other people that we can mention. We can set that up. So. Thanks again. If anybody understood better than me, please do. This is my understanding of sir's. Yeah, that's.
Just one question. How can we use the district residential posting to incorporate some of these thoughts that we went through in these 3 days?
Thank you, sir. It occurred to me also. So we have a district residential posting, which has come in from the government, mandated by the NMC and the state. And our postgraduates are all going there at the broad specialty level. How can we implement some of these into the district posting? Because they are going to be immersed into the government services. If there are any suggestions on how we could do that.
My work involves collaboration with a lot of non-state and other actors. I think one thing I found it difficult to learn on the job is I went from being at the bottom of the food chain in internship to being in a quasi leadership position in the sponsorship obligation. And later on in my career, willingly or unwillingly, I found myself in a leadership position, having to lead a team as small as maybe a ward or a unit, to like large scale interventions across a whole country, having to engage with political leaders. Sometimes I've even met like presidents and stuff. So I did not have any people skills or any leadership skills. I was wondering how relevant some sort of management skills are relevant for medical education, especially within our context, because we are all grassroots doctors.
Just to answer Shini's question, now at broad specialty level, last year, in fact, and Dr. Tambu is not here right now, but we actually had a post just before people went for exams after at the MD training. We had a workshop just for leadership empowerment involving legal, pharmacy, those kind of inputs, and we are hoping to make it a regular feature at the postgraduate level. But I know, Shani, you're talking about even at undergraduate level before we send people out. So we'll have to tailor one for that also. We were right now thinking at postgraduate level, but I agree with you. You could even be in a leadership position going fresh out of internship, which is rather like being dropped in the middle of an ocean, not knowing how to swim. So the point is taken. But in response to Dr. Sam's question about the district posting.
Who are expected to do a district fieldwork study for 6 months. Okay. Yeah, for the question that just came about for the district, how long is that, Philip? 3 months. Okay. So yeah, that's a pretty long period. What we have required our students to do is a 6-month period. So we're 1/4 of the MPH course in studying a district health service system and studying a village and its people and what they do for health and looking at the bridge or the gaps between the two. Now, 3 months could be, one could select a particular program and be looking at it, but look at it from the structure of the program down to its implementation to how the villagers actually experience it, what is their perception of it, what is the need they feel of something like that or something very different. So this is something which is doable in a 3-month fieldwork period, and you're going with something in mind to be looking at, because you really, we will see what your mind is looking for. So something like that maybe.
Thank you, ma'am. Anybody else on? I think that's interesting, ma'am. That would work well with the mandate of the posting and where you are. Sir, anything else to add for that? There's just one suggestion, an appreciation saying great conference, but needs follow-up. Medicine training will need a new perspective in training based on the recommendations of the workshop. I think this is more of a comment. My friend at the back actually put up a hand first, if you don't mind.
Thank you, ma'am, for the time. So first of all, I'm really grateful to be in the presence of a lot of eminent personalities. Just some thoughts from my behalf. So the thing is, one thing that I've noticed, I just finished my PG probably 5 years ago. So one thing was I've noticed that with medical education, or rather it would have started right from your primary education. There is a race to be getting validated through degrees, or the next, who is the next gold medalist or whatever. So the emphasis actually on, getting more degrees and medals. So I remember one experience I had during my post-graduation time was that I had come late for a class because I had to help an elderly man who had lost his way in the hospital. So I was actually scolded by my seniors and all. He was like, "This is not necessary. You have to be more. You have to make sure that you are in the good books of teachers by being." So you tend to feel lost. So as a budding doctor, you feel like, okay, you are in that dilemma as to what do we give emphasis to. Even at times when we were taught about care, it's more from a patronizing viewpoint. It's not like a doctor goes down to the level of the patient. It's more like a patronizing way that we are taught to explain things to the patient. And another thing is, I remember growing up as a kid, my mom, who also happens to be a doctor, she had a lot of idea about the society that is currently, like what social affairs and whatever. So those discussions used to happen at home. And with time, I feel like in current medical fraternity, the people I mingle with tend to feel it's a niche community. Like we have secluded ourselves with what is actually happening in the non-medical community. Also, let's say there is some community work that's happening in the city that I'm in. It may not be directly a medical activity, but there's something to help the community with. But we are kind of like secluded, saying, okay, this is not something important for me. My emphasis on the next new drug that's coming up, or the next new innovation, or the research paper. For example, when I plan to come here, so it's around 3 hours journey from Pondicherry. So I have many of the colleagues ask me what topic it is, and so when I said it's equity, for 3 days on equity, it's kind of not really a big thing to attend. What are you going to gain out of it? It's something very old-fashioned. So right now, when I'm on the other end of the spectrum, where I'm the teacher, like I have to train postgraduates and undergraduates, explaining care is very difficult. They say it's a very old 90s thing. And there's no necessity to talk to the patient so much. So let alone talk, going towards, emphasizing on social equity is a big hurdle. So I guess conferences like these, plus I think in general, we should have a variation in the curriculum as such. And I remember watching this movie called Patch Adams, a Robin Williams movie, where when he enters medical school, the professor says, "We are going to drive out humanity out of you and make you better species." It's called doctors. So I was very scared. I was like, okay, well, when I actually run, now when I look back, I'm like, okay, have you actually managed to do that? So yeah, that was a comment. Actually, as a doctor, when I was in the sense, and during PG also, I felt there was an unnecessary emphasis on who is in the better in the good books of teachers, and not who is more kind or has more compassion. Yeah, thank you. And I'm really grateful for having given this opportunity to attend this conference and such lovely topics. I hope it happens every year. Yeah, thank you, sir.
This was just like a follow-up to the question that was asked on research in secondary hospital settings. And so I think right now I'm in a medical college, so it's not an issue. But I think for 2 years when I worked with an NGO or out of the mission network hospitals or another NGO, one issue that was there is that when you're trying to do research, there is no obvious IRB or an obvious IEC that is there that you can apply to. So I think one of the questions that was, how can CMC help? I think if there can be a body that can review outside, like from secondary level settings, that can actually review scientific process and ethics process, I think that would be, something that could really help something realistic that could actually be done. Yeah.
Can I just respond?
மீண்டும் வணக்கம். ஒன்னில்லை, இப்போ நம்ம இந்த 3 நாளா சாதாரண பாமர மக்களுக்கு சிறந்த மருத்துவம் கிடைக்கணும்ன்றதுக்காக இவ்வளோ அக்கறையோட எவ்வளோ பெரிய நிபுணர்கள்லாம் இங்கே ஒன்று கூடி இது 3 நாட்களாக ரொம்ப சிறப்பாக சிஎம்சி மெடிசன் பொறுப்பெடுத்து நடத்தி இருக்கிறாங்க. இதுக்காக எல்லா பகுதிகளிலிருந்தும் மக்கள் வந்து அவங்களுடைய அனுபவங்கள் மூலமாக இது எப்படியெல்லாம் கொண்டு போக முடியுன்றது மட்டும் இல்லை, செய்து காமிச்சிருக்கிறவங்களும் அங்கே வந்து பேசியிருக்கிறாங்க. இது எதுவும் நம்மோட நின்றுடாம அந்தந்த பகுதிகளில் ரீஜனல் லாங்குவேஜில் இந்த 3 நாளை 1 நாளா சுருக்கி கூட இது யாருக்காக பேசுறோமோ அவங்களுக்கு போய் சேரணும்னு நான் நினைக்கிறேன், இல்லையா? ஆகவே இந்த முயற்சியை எடுத்தீங்கன்னாக்கா இங்க சாதாரண மக்களுக்காக நாமெல்லாம் சிந்திக்கிறோம். நாம என்ன சொல்லிக்கல, இங்க வந்திருக்கிற பெரிய நிபுணர்கள்லாம் எவ்வளவு அக்கறை எடுத்து இதை கொண்டுட்டு வரணும்னு நம்ம நினைக்கிறோம். இது எல்லா மக்களுக்கும் எல்லா பகுதியில் இருக்கிறவங்களுக்கும் இந்த செய்திகள் போய் பரவணும். அதற்கு வேண்டிய அடுத்த கட்ட முயற்சியும் சிஎம்சியும் மெடிசனும் எடுத்துக்கணும்னு கேட்குறேன். டாக்டர் சாராம்மா அவர்கள் இதை தமிழ்ல இருந்து ஆங்கிலத்தில் சொல்லிடுவாங்க.
This one I understood, but still, Sarah ma'am.
I think what he was trying to say was that the focus for these 3 days has been on how you provide help to marginalized people, or to people who really need it. And that people have come from all over the country who have shared their experience in doing so. And his request is that this doesn't get lost, and that this learning here is taken back to the places where we have come from and shared not with your peer groups, but with the community that actually we talked about. So if that is to be done, then that has to be translated into local languages, and that is his hope. Seriya?
I just go to Sushil wanted to. Yes.
I think you raised a very interesting and valid point, is that we have secluded ourselves from society. I'm not mistaken, Ida Scudder belonged to a tennis club and she was involved in the town. When I was a kid growing up here in the 70s and 80s, many of our senior professors were part of like Rotary Club and other social organizations, and they achieved a tremendous amount and brought in a lot of goodwill also. So I think it's shame on us because we are not getting involved.
I'll keep this as a last comment in the interest of time.
Yeah, so we all are working in our own areas, in our own special domains, living in our own cocoon. But such conferences for me is getting myself recharged for next 1 or 2 years, getting a lot of ideas about what others are doing and which I can replicate in my own places, and meeting many friends, making many new friends, maybe friendship for lifelong. So I really felt very nice to be a part of this. Thank you, Anand, for the opportunity. And I wish such gatherings keep on happening and we get a chance to recharge ourselves in this stressful environment. Second thing, I also wanted to say that we during our MBBS, doing, like, you are very much senior, but even in my MBBS career, we had various role models in the medical college itself with very good clinical acumen, clinical skills, surgical skills, and they were very ethical also. But right now, apart from maybe CMC or Sevagram or few other hospitals, in all other medical college in across the country, there are very less such role models. People are just coming there for 1-2 years. The teachers are going. So the students are not getting the good environment for developing their clinical acumen, for having at least the interest in research. And because of the new NEET and NMC, they are preparing for a NEET right from first year of their college, and avoiding the clinical and other acumen. So I don't know, but we have to somehow find ways to invest in the students because they are the futures. Yeah.
Thank you, sir. And that's indeed what we need to do. And well said indeed. So I think we will have a vote of thanks, but I'd like to thank sir again for on behalf of our department for putting to this together this process. And I think it's been a learning process. I won't call it a workshop or a CME. It's just going to be something that we learn, and we're all lifelong learners in medicine. I just like to ask members on the stage anything more to add. Otherwise, I will hand back to Dr. Sarah. Thank you so much.
We have had 3 very intense days. And as we leave, I want to take a little time for each one of us to just be still and reflect a little bit before we go into the next session of closure. And to help us, I want to read a poem which is untitled, but which I would like to call Involvement. Do not retreat into your private world. Do not retreat into your private world, that place of safety sheltered from the storm, where you may tend your garden, seek your soul, and rest with loved ones where the fire burns warm. To tend a garden is a precious thing, but dearer still the one where all may roam. The weeds of poison, poverty, and war demand your care, who call the earth your home. To seek your soul, it is a very precious thing, but you will never find it on your own. Only among the clamor, threat, and pain of other people's need will love be known. To rest with loved ones is a precious thing, but peace of mind exacts a higher cost. Your children will not rest and play in quiet while they still hear the crying of the lost. Do not retreat into your private world. There are more ways than firesides to keep warm. There is no shelter from the rage of life. So meet its eye and dance within the storm. Can we just keep a moment of silence? Think about the 3 days you have been here and make your own commitments about what you will do when you go back to your homes and to your places of work. Just a minute. Thank you. Thank you. And I'm going to ask you now to please offer to one another, to those around you, a greeting of strength and peace as we say goodbye and continue on our journey. So just turn to your neighbors and offer a greeting of peace and of strength and solidarity as we move forward into the next stage of our journeys.
Like to thank the panel again.